Good day. Well, when all things don't work out the way we expect in life, there is the introduction of anxiety and stress, which can lead to psychological disorders. Now, the idea that psychological disorders are biological is part and parcel to many thinking processes in healthcare. Because what we see is psychological disorders following intergenerational lines. Now, hunting down whether the intergenerational transmission of psychological disorder was biological or just similar environmental circumstances which led to a sociology that promoted that disorder as transferable is an open research question. But let's start with the common notionality about PTSD, post-traumatic stress disorder. It's just a reference point because it's common amongst war vets. When a person experiences the unfathomable, it creates a delta between who they are as a person. You don't wake up in life one day and just decide you would like to go to war. War is an unfortunate outcome of failed political sociological constructs. And one might say it's a necessity, and when one goes into the military, they take an oath to follow orders. Now, whether those orders are congruent with their personal id, what Freud would say, what our notion of ethical and morality and our childhood development relationships is another question. And when that delta exists between who we are and what we are expected to do, the anxiety creeps in, which can lead to disordered processing. How do I make sense of this? I was following orders. And so PTSD, because of the trauma and because of the events, is common amongst war vets, and as such, easily diagnosable with the symptomology. But when we're talking about symptomology, over time, we've learned using diagnostic science to understand what genetics are unusual but not abnormal. Unusual might have at one point created a view that people with red hair, for instance, have disordered genetics, when in fact, even though that was unfortunately placed upon people with red hair at points in history due to science that wasn't fully vetted, it isn't actually a disorder. Culture can be confused as a disorder. For instance, some cultures make eye contact, other cultures don't. And so the lack of eye contact needs to be mitigated against the cultural norms of the individual before confusing it as a disorder. What we see here is over time, the breakdown of psychological disorders comparing the percentage of prevalence among adult males and females in the United States. This data is from 2007, and the categories here are from the DSM-4 and the DSM-5 diagnostic manual. These categories remain the same. However, alcohol abuse has been brought into alcohol abuse disorder category. So what we see is the total and the males and females breakdown associated with variety of symptomologies. Every one of these symptoms might be diagnosable as an individual disorder, but it also might be the symptom of a greater disorder. So under post-traumatic stress disorder, we see that females are slightly above males. Slightly above the total, largely above the males in diagnostics. But a person with post-traumatic stress disorder is commonly diagnosed with anxiety, possibly panic, and certainly major depression as well. Those are called comorbid symptoms. Just like if you show up to your doctor coughing, they could come to the conclusion that you have COVID without any testing, but they also could be a common allergy, a common cold, many other things in which coughing disorder could be diagnosed, but part and parcel to a larger diagnostic criteria. So, for instance, in psychology, the comorbidity between obsessive compulsive disorder and major depressive disorder is 41%. Obsessive compulsive is also have a comorbidity with anxiety as well, because actually obsessive compulsive disorder is an anxiety disorder. So when symptoms co-occur, what we're referring to is the physical manifestations can happen irrespective of the particular diagnosis. So you could feel dizzy, shortness of breath, chest pain with COVID, but you could feel dizzy, shortness of breath, and chest pain with an allergy to pine cones, or an allergy to dogs and cats, or an allergy to food, or the flu. So what we also have talked about is the effect of worry and anxiety, because worry and anxiety are motivation deficits, which limit performance. And as such, not only because of the limited capacity to perform, but also because of the sheer bandwidth that anxiety takes out of a person's capacity to function on a daily basis, the anxiety and the worry creates a delta between who the person is and who they would like to be able to actualize on the Maslow pyramid. Mood disorders are categorized by massive disruptions in mood. Symptoms can range from extreme sadness and hopelessness to depression to extreme elation, which we call mania, or extreme depression, which we call chronic depressive disorder. So a mood disorder is categorized by disruptions, inconsistencies, back and forth on mood, which is disruptive to performance as well. So PTSD was first recognized in soldiers in combat, as we talked about. PTSD also extends into childhood experiences beyond just the war vet example. So childhood maltreatment interferes with normal childhood development that Piaget, Erickson, and Kohlberg would imply is necessary in order to thrive as an adult. In fact, this gene study interaction in people experiencing chronic depression in adulthood suggests that childhood maltreatment, exemplified here in this graph, where those with childhood maltreatment are over 400% higher incidences in chronic adult capability deficits, we notice that those deficits were written back to this gene environment. A person would not be born with complex trauma or CPTSD, complex PTSD. It requires childhood maltreatment of some sort, generally from a trusted adult who that child believes would not have steered them in the wrong direction or done wrong against them and found out differently. Betrayal, maltreatment, actually writes back to the gene complex of that individual. And that gene complex drives their experiences and successive thriving capacity as an adult. In theory, that experience as a childhood written back to the gene structure could be passed down intergenerationally to the next generation. In theory, open research question which needs more work. So what we look for in developmental disorders is red flags, behavioral red flags. In the example of COVID, one coughing, one sneezing, and shortness of breath are physical manifestations. Though physical manifestations might be part of disrupted development and a psychological disorder processing, but also behaviors could become part and parcel. And in this example with OCD, we see that a person feels as if, because of learned experience, that washing their hands 3 times is necessary in order to get the germs redacted to a safe level. Now, is that irrational? It isn't if that person experienced priorly a parasite or bacteria that came from not washing their hands. And hence, we might say it demonstrates some level of paranoia, but it also might be rational paranoia in the sense that one has learned to behave in a certain way to avoid past traumas. Unlocking and locking the door 3 times might be disordered behavioral red flag left over from a burglary incident that happened because the door didn't get fully locked. Again, there's a certain level of rationality that leads to a behavior that is no longer in alignment with the modern circumstances. Is washing one's hands 3 times in alignment with the circumstances a person faces 2 decades down the road. It may or it may not be. And breaking that fixed action pattern of thinking and behavior might be difficult. And in doing so, create anxiety that might lead to a behavioral red flag or a telltale sign of common obsessive compulsive disorders, OCD, or high levels of anxiety that are debilitating. Other chronic behaviors might be hoarding. Fear that the most important thing that you need might get thrown away, might lead to collecting things that one does not need in order to short circuit the risk of losing something important. Science evolves over time, though. And what we have learned is that even just in the modern era, not that long ago, in the 15th century, surgeons would operate on a person's brain in order to attempt to control obsessive behavioral problems, in this case, reducing a stone of madness from a person's brain. Now, I don't know exactly what got extracted here, but what we do know is there is no stone of madness, and that behavior is a protection which will only modify itself if the experiences and the safety, security, and comfort of new relationships allow it to. But at one time, there was a view, maybe in 1500, that dancing was a mania-driven disorder, and that the behavior of dancing was influenced by supernatural forces. And then people would be treated for dancing. We've learned since that, that is not a psychological disorder, but who knows, 100 years from now, will they look back on some of the things that we're doing with suspicion that we didn't have absolute science behind it all. So when we're trying to diagnose a psychological condition, the idea is to look at the genome, the sociology, and or both. And in this case, for instance, with schizophrenia, we're looking at it occurs in first cousins, uncles, nephews, grandchildren, and half-siblings at high percentage rates, and in parents, siblings, and children with shared genes in high percentage rates, and in identical twins. So the percentage risk of developing schizophrenia is high, genetically. But another question might be, is it because these different groups of familial, family interactions are experiencing the same sociological phenomena, not only in the family, but just in the larger micro and macro social groups that one is involved with? And is that an influence? And is that influence the primary factor or combined with the genome factor? Now, different regions of the brain are associated with different psychological disorders. Interesting, our brain stem ends where the hippocampus and the amygdala are making decisions on fight, flight, or freeze, meaning impulse decisions based upon fixed thinking. Once the risk is determined to be low or lower, the processing then is assumed can take more extensive time reviewing memory, reviewing experiences, and pulling in more data, and sends to the prefrontal cortex for that processing. What we have found is that hoarding disorder is centered on the anterior cortex. The body dysmorphia, which is eating disorder, is centered in the prefrontal cortex. And obsessive compulsive disorder is the orbital frontal cortex. So we could see in PET scans the processing deficit that leads us to the fixed pattern of thought, that even when we have the chance to send the data processing to the prefrontal lobe, that at times the prefrontal lobe will settle on the idea that body dysmorphia is a valid construct and will reinforce it in our lives, or other perceived disordered processing. Medications designed to treat these disorders work by altering neurotransmitter activity in the neural synapse. So if one is prone to OCD, obsessive compulsive disorder, then the neural transmission on retrieving data and acting on that obsessive compulsive disorder can be modified medically through an SSRI and SSNI in order to reduce anxiety, reduce depression, reduce the underlying symptomology by increasing serotonin, dopamine, or other norepinephrine, other neurotransmitters in order to avoid the anxiety that might lead to obsessive compulsive disorders such as hoarding. We do know that there's longitudinal studies, and a longitudinal study is one that was done over a long period of time, in this case from age 10 to age 16, 6-year study, in which risks of various activities are predictors of later violence. So a person involved with a gang at age 14 and 16 is a high predictor in middle school and high school of gang mentality. Peer delinquency is a predictor of relationships that are delinquent lifelong. Sociologically, economic deprivation, lacking food, shelter, and water in age 10 through 16 leads to that phenomena occurring lifelong, the same as availability of coping mechanisms of drugs and alcohol.